Thanks, Ashley. And thanks for all of you for joining this webinar today. We have a fantastic panel to really cover why we need to move into the care at home space and how hospital length of stay and other factors are really impacting the care that we're providing patients today. I wanted to start with a few grounding statistics out of the American Hospital Association, just to help us frame, I think, what we're all dealing with in healthcare today and help us understand some of the factors that are playing into this. We have a workforce shortage, a workforce problem. We know that American Hospital Association has found that 80% of nurses report feeling burned out, citing low staffing as a factor. We also know that low staffing has impact on our patients, and there's plenty of data in the literature to cite that. Studies in 2013 and 2011 show that RN staffing, when they have insufficient staffing, we know that patients have higher hospital readmission rates. We also know that patients have higher mortality, and our patients are sicker. Coming out of the pandemic, this pent-up need and desire for healthcare has only grown. And we also know, courtesy of AHA, that patient acuity has increased consistently each year since 2019. We know that average length of stay for hospitalized patients in specific categories has increased. Specifically 89% increase in average length of stay for rheumatoid arthritis patients and 65% increase in length of stay for certain cancer patients. And then another kind of survey of primary care physicians has found that 37% are saying their patients with chronic conditions were in noticeably worse health than pre-pandemic. So all of this is really causing a jam in the hospital, and length of stay is increasing. And we are on a mission at Bioformis to create solutions to help hospitals, healthcare facilities kind of have an off valve to that and get patients out of the hospital. I'm your host today. My name is Sarah Bell. I am the Vice President of Customer Success and Clinical Implementation with Bioformis. I want to introduce my esteemed panel who is here today and offer them my many thanks for allowing me to ask them questions. So we'll start with Khurram.
Thank you, Sarah. I'm Khurram Mir. I'm the Director of Innovation here at UCI Health, and also lead system-wide innovation, where we're looking at business problems and how do we really find solutions, existing solutions that we have, or partner with the external solutions. And on the flip side, I also work with the UCI Health Ventures arm, where we are looking for startups that are solving for some of our core business problems. So glad to be here. UCI Health, for folks that are joining, is one of the health system enterprise of the 6 UC health system enterprises that are out there that roll up to the UC Office of the President. And we are an academic medical center. We're a level 1 trauma center. We're a burn and NCI designated cancer site. So with all that in the backdrop, during COVID, the capacity problem just exacerbated. So glad to be here. Thank you so much, Sarah.
Thank you. Lauren?
Yeah, hey, excited to be here today on this beautiful Thursday. I'm in Augusta, Georgia. I'm Lauren Hopkins. I'm the Assistant Vice President for Virtual Care and Community Engagement at what was formerly known as AU Health. We actually have recently partnered with a large health system in Atlanta region, and we're really excited about this for Augusta and our region we serve. My name of the hospital is now WellStar MCG Health, and we're part of the larger WellStar network here in Georgia. Very similar to UC. We are also an academic medical center. We are the state's actual academic center here. We're a level 1 trauma center, a level 4 PICU. We service a 14-county region called the Central Savannah River area that borders not only here in Georgia, but also crosses into South Carolina. And my work really crosses a lot of areas, not just in virtual care, but also our community relationships and community partnerships, especially with our rural partners across the state. Part of the other work I do is a lot of expansion into rural Georgia to really focus on rural sustainability with our hospitals and rural partners. And being part of academics, you do have the research side, which is really fantastic. So we do a lot of grants and are working really hard to build up our MCG Center for Telehealth to grow research collaboration, to really grow virtual care research, not only here in an academic center, but across the state and a lot of rural areas that don't have access to that type of research. So excited to be here and be a part of this panel.
Thank you. And last but certainly not least, Dominic.
Hey team, excited to be with you all today. My name is Dominic Paul. I am the newly appointed nurse administrator for virtual care at Mayo Clinic. In my role, I have the privilege of overseeing a lot of our different virtual nursing and even virtual care solutions. Today, largely my focus is on our inpatient service line, our virtual RN service line, our outpatient service line, or remote patient monitoring. And then I do have some oversight over some of our telesitter practice, a connection to advanced care at home, our hospital at home service line. Our colleagues in the EICU interface with our inpatient virtual nursing team, and then also oversee some of the facilitated self-care interactive care plan technologies with that. And so Mayo Clinic is a health organization with impact in Arizona, Florida, and Minnesota. Me personally, I'm in the Rochester, Minnesota region. And so excited to be with you all, and huge appreciation to ATA and to Bioformis for co-hosting this. It's a super important topic, and really excited to chat with you all about that collectively. We as a healthcare community have so much to learn from one another about this. And I think this is a really good opportunity for us to talk about how we're seeing success in this space, and also what are some of the challenges that we need to rally around and figure out together.
Yeah, absolutely. And thanks for the setup there, guys. And I think I wanted to dive in first and just really talk about how has this increase in length of stay, other factors coming into staffing really impacted your organization. I mean, we're dealing with health systems that cover a large chunk of the country in the South and the Midwest and in the West, and curious to get your thoughts on how it's impacting your organization. So I might just kick it over to Lauren first.
Yeah, so with us being level 1, really servicing the larger part of East Georgia, it has, obviously we, even pre-pandemic, we're on diversion, we're dealing with, bed capacity and throughput issues. And so we had already begun task force related to patient throughput, right? How do you get patients in and out of the door? How do we help screen some of this out prior to them even getting to the hospital, right? What can we do with partnerships with the EMS? Or we were a part of the ET3 program, for those who may be familiar with that. So we have begun these efforts. And then obviously when COVID hit in 2020, it just completely changed the game. In a lot of ways, the things that we have been talking about of how do we expand telemedicine, how do we really improve upon digital use cases to grow and to help our patients, help our providers, really got accelerated, right? I think we all felt that. If you've got to quickly now turn on a way to start using telemedicine in your hospital setting. And as COVID kind of progressed, we started targeting ways of trying to help with patient throughput. And part of that was our rural virtual care network initially. And we have a very large, it's a 16 hospital network where we actually support telehealth in these rural facilities by keeping patients in their rural homes, right? And that was great for a little bit, but just like everything, you have to continue to evolve. You have to continue to figure out solutions, because even though you may have solved for one problem, you've still got your finger in the dam on other holes that are, water's coming through. And so what we've been really seeing a lot of, especially during the pandemic, where the state of Georgia received a waiver to expand Medicaid access. That went away recently in July. And we've really felt the impact of that, because just like what Sarah's statistics were saying, these patients are sicker and now they don't have access to healthcare. So they're sitting in a hospital bed, no access to get their DME, no access to get home health. And you're trying to find out ways to actually deal with that. And that's really been the biggest piece for us, is I would say from a length of stay perspective, medically, the patients are okay. It's the social issues we're really starting to deal with that we've got to figure out how do we tackle them. And that's been a really a challenge for us and our providers, right? Our providers don't want to let those patients go into the street knowing they don't have what they need, but we're not a hotel, right? The patients can't stay here. So that's really been the biggest challenge for us. And then also too, I would say, going back into the burnout area, yes, for nurses, but we've really seen a big piece of burnout is in our case management staff, right? They're the ones having to figure this out. You've made them now problem solvers of how do you fix housing. I can't build a house right here and snap my fingers and it's available. So those have really been key features for us that have impacted us really driving into more care at home models. And how do you create not just care at home, but that community outreach? Because some patients are never going to go into a digital care at home model, but you can also still solve for other solutions by having a community partnership or a community network. So for us, I would say the biggest piece has really been the social problems that we've had to deal with. And then, of course, when Georgia, the waiver went away in July of this year, we had a lot of residents that lost access to healthcare services or insurance, excuse me, and that really has impacted us financially, as well as now the patients coming to the ER versus access in the clinic, and clogging back up that ER again.
Yeah, absolutely. Couldn't agree more. I think the waiver hit many of us who are dealing with, had the luxury of allowing patients to go into some of these digital programs without the cost associated. Definitely has been a barrier. Hopefully we can get back there. Dominic, do you want to dive into a little bit how at Mayo Clinic has length of stay impacted, and what does that look like there?
Yeah, good questions on this. And I'm thinking about your statistic too that you quoted around the cancer patient population, and I might jump to an idea on that in a moment. Length of stay, what I would say is if it's not impacting your organization, it's impacting others, right? And it is therefore impacting your organization, because all of that shifts who, when, and where you're going to see these different patient populations showing up. And we saw a ton of this throughout the pandemic, right? This isn't new news, where we had this overwhelming amount of patients entering into our hospital doors that needed very high acuity needs. And we were standing up units, opening doors to rooms that we hadn't used in a long time, things of that sort to help meet that need, right? And all of that creates this downstream impact to other patients who also needed care, who were challenged to receive that care, right? I remember really having to sort out what were the surgical procedures we were going to be able to perform each week, because of some of the volume constraints that we were experiencing within the brick and mortar. And what's a beautiful opportunity here is sometimes the solution to the challenge in the hospital is actually in the outpatient environment. And so a brief example of some success that we've had in this space has been through the development of some RPM programs. And the shift for us throughout the pandemic in our RPM program at Mayo was from this chronic condition management space and really into a higher acuity post-acute space, in which we saw a lot of success with a really short-term approach to a COVID-19 program, in which many of our patients that we were thinking may need hospital level care were able to be managed in their homes through an RPM program. And so in addition to that, what we did is we started to build on that. We started to think about what are some other acute patient populations, especially patient populations that really don't want to be in the hospital, that we can be creative around. And one of those patient populations we've seen a lot of success with has been our cancer patients. And so I'll throw out there an example. Today we have a neutropenic fever program that's largely focused on patients within the hematology and oncology spaces that are at risk for developing febrile neutropenia. And many of those patients hang out within the brick and mortar walls because of their high risk sort of status. And we've been able to shift those patients' hospital stay to a home or like home environment, whether that is actually their home, a local Airbnb, or a hotel nearby. And those patients are in a much, much better, much more amenable sort of situation. And gosh, I think it's super important for this patient population. Some of these patients are in their final days, right? And gosh, they don't want to live out their final days within the brick and mortar. As good as we are at delivering care to these patients, they love the opportunity to be at home with their family members. I can think of a story just recently of a patient who we were able to enable being at their wedding that they were planning to be at. And without this RPM program, they would have been in the hospital performing that ceremony rather than at their ceremony site for that experience. And so these are some of the emerging opportunities that I really see in the space for us to continue to really think about what are the patient populations we can have a great deal of success with that have minimal physical care needs, but can be significantly enabled through digital and virtual engagement, whether that's with nursing or provider or other team members. There's so much opportunity in this space.
Thanks, Tom. Really appreciate that perspective. Karim, want to give you the opportunity to talk about length of stay in your area and what that looks like and the impacts associated.
Yeah, thanks, Sarah. I agree both with Lauren and Dominic on this. And just to give you a little bit of perspective on, we are also a safety net hospital. And at the same time, we were a level 1 trauma center. So during COVID, of course, the capacity problem exacerbated. We had some RPM-like platforms at play when we started this journey, but it went into high gear. How do we really solve for our capacity problem? And going back to what Dom was saying here earlier, is there is a virtual component to some of the patients that can be safely discharged into the home, and there are those virtual checkpoints that we can do. So we did launch a couple different efforts around remote patient monitoring, and we were successful. As a matter of fact, a couple of our clinicians even published, and they were able to showcase that they were able to send a patient home and save on length of stay. So I think there is a huge element around these digital touch points that we can do to really enable the care in the home by creating that capacity. So being a safety net hospital, we also opened our doors were open to pretty much all the population that we could see, and we had to also, hallways were open, any room, like Dom mentioned, we were seeing patients in every corner of the hospital, and we had to build out a tent as well. So capacity was paramount for us. So the digital tools have allowed us to do that, to be able to then transition some of these patients in the home setting.
Yeah, no, it's fantastic. And I think the chat and Q&A has been flowing already. So thanks to those who have been submitting questions. I think there's one interesting question, and it comes around to health equity, as we talk about in this space in particular, with the waiver going away. And, you could argue that creates a little bit of an equity issue. I don't know, Lauren, you're being in the South and AU having that, health equity is front and center for you guys. Do you want to talk a little bit about how you address some of those social issues and what that looks like in the digital care space?
Yeah, so in our model that we started in February of 2021, really as a direct response, just like what the rest of the panel is referencing of COVID, we started discharging patients into a model where we monitored them 24/7 virtually. What we found as we have evolved our program since that time is there's so much opportunity for really in-home care models, whether that be true in-person care, you're sending a paramedic or you're sending a nurse, and also to the actual components of virtual remote monitoring, telehealth, right? It's all there. And what we really found in this model was this really enabled people who may not have access to be able to get their DME, or maybe they didn't qualify for home health. We now can go in the home and do wound care, right? I can go in the home and do IV administration for these patients where they're struggling. They couldn't get it in an inpatient setting, prior authorizations, or they couldn't pay for it. We've built our model as a purely cost avoidance model, which is very unique because we're not actually billing patients for services in today's model that I have, which is patients who are truly outpatients. They are discharged patients. We did it because we saw the length of stay reduction this program had on our institution. On average, every patient we discharge in the program for cutting down their length of stay about 1.56 days. And so because of that, the institution recognized the value of this program. What we have really seen is that this program really can improve health equity and address some of the social needs in our program. We started out as really a short kind of 5 to 7 day approach, just trying to help with throughput. And what we've done is we've actually evolved it to basically a virtual step down unit from there. So if a patient requires medical intervention, they stay on what we call our post-admitted home program. When they get to a point where they don't need medical interventions, no labs, we're not changing up their medications. It's just remote monitoring at this point in time, daily tuck-in calls or visits with the nurse. We move them to enhanced care. And enhanced care allows that patient to be on a journey for 30, 45, 60 days while we are really putting them first and focusing on what do they need in order to be successful long-term dealing with their chronic conditions, whether that is diabetic education, whether that is medication maintenance, getting in a routine of how do I take my insulin, understanding those barriers, right? Going into the home and figuring it out. We have interdisciplinary teams that are a part of this. So paramedics, nurses, social worker, pharmacists, physicians, that all contribute, right? Because you have a paramedic going in the home, she sees the home, she knows what's going on, and then you're able to bring that back to the physician, to the social worker, and create a game plan that really allows for more sustainable success, not only to help reduce readmissions, right, and to help reduce ER visits, but to really help empower that patient to deal with their chronic issues. And that's really been our focus of this, of how do we continue to evolve this model to be one that does allow the patient to be in the center always and meet them where they are, even if they don't need in-person care or they don't need continuous monitoring, they still need some level of support. So it's taken it a little bit of a different direction. I'm really excited about where we're heading and continuing to evolve to really meet and improve these disparities in care that we're dealing with constantly in our population.
Anybody else want to tackle health equity?
I'd like to chime in, Lauren. I think you hit a really good point there where you're not charging patients for certain things. And for us, when we launched our program, we wanted to make this as equitable as possible. We didn't want to charge our patients. So we literally wanted to, any patient that qualified clinically to be able to be discharged safely into the home was able to do that. So I think that's a huge element. And I was just just getting ready for this webinar last night. I was reading a statistic last night around how 24 million people don't have access to high-speed internet. It's just blows my mind, right? UCI Health is in an urban area. We don't have those issues, but Augusta, you guys might. And hearing you say that, and there's just this disparity that still exists. And another statistic that was really just mind-boggling was this: 40% of the population we can address some of this the SDOH issues for just using digital tools. And we see that because in our population, so we have remote patient monitoring, we have mobile urgent care. And when our mobile urgent care goes into the home setting, they see all these other factors that the patient does not really disclose at the time of discharge. So we get this other picture of a patient that we were not privy to. And that really helps. And that chart comes back to us. So it really creates this new wholesome picture of patients. So I think it's imperative for health systems to be able to stitch these visits together to be able to get a really good picture of a patient on how their other life outside of the hospital is impacting them, that is forcing them back into the hospital. So I'll see if anybody else wants to chime in.
Dominic, anything to say on that?
Just add one really brief thing is we built out our RPM program, and this has impact and influence and other things we do in the virtual care space. The access to the tech and the devices and that sort of thing is something we've been really thoughtful about. So a couple of items. One, we're working on a lot of multilingual components to these programs to assure that we can meet the needs of patients beyond English speaking. We saw this as one of our gaps throughout the COVID-19 pandemic. And in particular, within some of our health system region in the Midwest, there was a large Hispanic population that we were able to have success with through that. Second thing I'll say is for our RPM programs, our patients receive a tech stack from us, right? So they're billed in alignment with the 4 CPT codes that exist for RPM services. They're not directly billed like durable medical equipment for the devices that we give them, right? And then that equipment comes back to us. And the equipment that we send out is also very purposeful in that we have an understanding of where that patient is regionally located and what some of the cellular network providers look like in that region. And so we're able to ideally ahead of time, get that patient the appropriate SIM card into their device so that when they open up their box, when it arrives on their door, they're able to pick up a piece of equipment and start engaging in a program that's pretty intuitive for the end user. In rare situations, we've tapped into the patient's in-home Wi-Fi, and there are certainly some opportunities for us to continue as a nation to expand into those spots and places within each of our states where we don't have great access to either internet or cellular connectivity. And as we break down some of those barriers, I'm really excited about the impact that virtual care solutions can have in those areas.
And
yeah, go ahead, Lauren.
yeah, to say that it is, yeah, we do live lots of rural areas in Georgia. I live in a rural community in Georgia, and we did have that issue, right? Where you don't have high-speed internet or great bandwidth, or even patients who have Wi-Fi, right? There's still tons of patients in our community who don't have Wi-Fi, who are using flip phones that are not smartphones. And so what we did is we partnered with our cybersecurity team and our IT development team here, and actually started taking out cellular hotspots, right? So boosters into the home. So we give these equipment to the patient. And that was been part of our journey as a RPM vendor, is finding a vendor who really understood our barriers and issues and worked with us on the equipment and the needs, and how do you make it just seamless, right? Because if they're having to troubleshoot, if they're constantly having to retake vitals, then you lose that engagement. And so that was a big piece of us as we've continued to evolve our equipment and peripheral devices we use, is finding somebody who understood those barriers. And then also too, working to actually give the patients the needs and the tools in their home in order so they can participate, because we didn't want that to be a limiting step and factor in their participation to improve their health.
Yeah, I do want to add to what Lauren, I think we're all saying the same thing, is to access meeting the patient where they are, and on their digital literacy journey as well. We had some experience from our senior health center, which we thought we're really grateful for, because they were doing some work on digital literacy. So it really helped us understand, how do we really bring a solution to the table where we can meet the patient, especially with ones that are going home. And we initially, when we launched the program, we had the whole BYOD model, and we're like syncing up phones and devices. And boy, that takes up a lot of your time, especially a very critical resource like a nurse that is trying to do that education, trying to sync up the devices. So what we really want to do was create a turnkey model where we're just rolling out a package where, if you're part of COVID, pneumonia, COPD, heart failure programs, we're giving you a set kit. You open it and it's working right out of the gate. So just want to chime in on that.
Yeah, no, thank you. And this is really good. And kind of some of the questions we're getting right now in the Q&A have been around staffing. So we mentioned length of stay is in the hospital. Staffing is a large reason why we can't get patients out. So the big question is, okay, how are you staffing these programs? And what does that look like? If we can't staff the hospital, how are you staffing these care at home programs? Dominic, you want to go first?
I would love to. I was thinking about length of stay last night, and I was like, you know what? There's another length of stay metric within healthcare that we are not paying enough attention to right now. And what is the length of stay of your staff nurses within your institution? That should be a metric that we pay a lot of attention to. And Sarah, you cited some bold statistics there, like, a bit of alarming, right? And I was reading this article, Rose Sherman published this just here in October. She's citing the National Council of State Boards of Nursing and the National Forum of State Nursing Workforce Centers here, estimating that by 2027, we're going to see 900,000 nurses leave the nursing workforce. And that's alarming to me as a nurse leader, someone incredibly passionate about the care of our patients and the care of our teams taking care of these patients. We need to collectively solve for some of those challenges. And so I can appreciate those questions in the chat of like, how are you staffing this? Because we're not, tripping over resources. And so good news, we're in the same boat, right? We're not tripping over resources either, but we are finding ways to work a bit smarter. And one of the longstanding issues within the healthcare industry, my opinion here, is that for a long time, we have had clinicians working for the technology rather than the technology working for the clinicians. And in partnership with many vendors within the industry space, we need to collectively begin to move this forward and really think about, how do we optimize the workflow, the tools, the design of these products for our clinicians so that we can make the best use of their finite time. And so we've been doing a lot of that and have had a lot of success in that space. Our RPM programs, they've been through a journey. We started very focused in chronic care management. We were a care coordinator and role from a nursing perspective and made a shift kind of post-pandemic toward really an ownership for virtual care as a specialty with a connection back to local practice providers or local nursing teams as more of those subject matter experts, because our virtual care nurses can't be experts in everything, but we need a team, a centralized team that can own and operate the tech. Kurum, you called this out of like, you can spend a lot of time troubleshooting devices and that sort of thing, and you can get a lot of erroneous data. And so having a team focused in that space has really allowed us to extend the reach of our nursing team. So we started with our nurses caring for about 30 to 40, even 50 patients on their panel, right? And we shifted to a team-based model. And today within our RPM space, our nurses are caring for 100 to 110 patients each. And we're able to extend our reach further and then reach back into those local practice experts when there's a patient need that arises that we're just not familiar with, right? It's a new disease, it's a different condition that we're familiar with. And we can tap into the right expertise at the right time, make sure we're still meeting those patient needs and even maybe detecting those before the patient might have come across them themselves. And so that's a bit of how we're tackling some of the staffing for this. And I just want to say, virtual nursing is something that your organization needs to really think about investing in because it is a critical component to the retention of staff within your organization in the future. And super passionate about that, could talk for a long time about it, but there are a lot of other pieces of wisdom from the others here. So I'll stop there.
I want to tee up Kurum and Lauren next. Sorry, I was on mute. It's my first day in virtual care. So having what Dominic hit on is staffing these services is have a centralized group of people doing the work. So doing the monitoring virtual care, we're going to create efficiencies there. Those efficiencies are going to mean we're going to need less people to do the monitoring. Kurum and Lauren, I'm curious your thoughts on, okay, how do you get people in the home? Home health agencies and other places are also strapped for staff. Are there strategies that you're employing in those spaces to be efficient, or what does that look like in terms of staffing that arm of it, the in-home care portion?
Absolutely, Sarah. If you wouldn't have called on me, I would have spoke up anyways. Because Dominic has more of a staff on site model. We are more of a partner model. We don't have a home health practice, so we were always on the lookout for a partner that we can work with that can help us with the monitoring of the resource of our patients. Because as we're transitioning these patients safely into the home, there are certain touch points we want to do on a daily basis on a very good cadence that we can then roll that back into our enterprise. So how do we do that? And that's where we relied on our partners in the field that are helping us be that touch point, both in home or virtually to check in on the patient. So that's the model we're doubling down on. But at the same time, we are also building our what we call it a care at home platform, which is our entire unit that is going to be dedicated towards it. So we're sort of looking at Mayo and like we would love to be Mayo one day, but I think that's kind of where the model is going to go one day. But right now, given that we don't have those building blocks, we're building those as we go. So throw it over to Lauren.
Yeah, so I have a traditional transitional care team, right? That just did your telephonic outreach for patients leaving the hospital and actually borrowed, they got voluntold, right? That happened during pandemic where they now started monitoring these patients. And the funny part about it, I'll say this, is they were my pediatric care coordinators, right? So they of course were like, what are you talking about? I've got to deal with, big kids. But they did fantastic. And what we started working on is very similar to what you just referenced is we had to work on partners, right? I had 2 staff members, so I had to rely on other vendors. But what we quickly found is that I worked very hard with my finance team to start putting the numbers together of what this true care at home model could look like from not just the acute care space, because we do have our waiver for the acute care hospital at home, but all the way to the chronic disease, and making it really a longitudinal approach to managing patients through a digital world. And that's really our mission, is in the MCG Center for Telehealth and here at Wellstar, is digital inclusion, people connecting to people, right? And so what we have really focused on is going, and we have really piecemealed. So we have a hybrid where I have dedicated staff that are focused on all of our care at home programs. They are cross-trained, so they know each of the processes for each of the various programs, but they have a dedicated group of patients they manage each day. Our staffing is not, we're working to improve and learning from leaders like Dom and like Sarah at Mayo of how to better utilize the tools that we have in front of us to become more efficient, to grow our panel. But right now in our world, we have a patient panel of our staffing ratio, for our patients that are in the post-acute model, which is where they require medical intervention, of 15-1. For our paramedics, we have a 10-1. And so that ratio is a little bit less, obviously, than what Dom just referenced in the 110-1. But we're working to get there. And our ones that do not require interventions, it's a 30-1 ratio right now. Now, part of this, though, for us has been, how do I attract, right? You referenced it, Sarah. If you can't staff the hospital, how are you staffing this? Well, this is a different model. And I think what we have found is people enjoy doing this work because I can allow them to work from home, right? I now have a little flexibility in the shifts and the hours they can work. They can stay at home and have, ability to be with their family, but then they're also working here in this virtual space. Part of that, though, is finding the right person for this, because not every nurse is going to be a good virtual nurse. And you have to really understand, they've got to be great communicators, because in a virtual space where you have everybody across the state of Georgia, communication is key. And you have to have great tools in order to be effective in your handoffs and your, collaboration. And so what we really aimed on is really looking at it from the perspective of, how do I recruit nurses who were burned out because they were having to be in the hospital, they were tired of working the night shift, and now all of a sudden I give them an opportunity to work a little bit in a flexible model. So that for us has been a piece of it, and not just in our post-acute world and our enhanced care, but also with our telemedicine programs that we have, telestroke, teleacute care. It gives that provider, that nurse, that clinician, some flexibility of maybe having a better work-life balance, right? You're going to still get burned out, right? It's still the same issues. They're just in a different space. But now you actually, because it is virtual, you can take a step back and kind of slow down and be able to look at that patient holistically, knowing they're in a, not good location. Maybe they don't have the base family support. Well, in the hospital, you're just trying to churn and burn, get out to get the next patient. And this model, I feel like our nurses are a little bit more empowered to realize I am also too, not just their provider or their clinician, but I'm really focusing on how I can better help them long term. And I think that in a lot of ways is a gratifying piece of why we're able to retain and recruit staff here, because it is such a different model than what you're doing and experiencing in the actual hospital setting. And I would say the same for our paramedics. We started hiring paramedics to go into the home. The state of Georgia is very fortunate that our protocols for paramedics allow for them to do the same type of services or have the same scope as a nurse, with the exception of administration of blood products. So we're very fortunate that we have the ability to use paramedics. And in our region, paramedics, EMS were completely burned out, right? You talk about the hospital staff, they were 100% burned out. They were working 120 plus hours, in 1 week. And it's just like, you can't do this. This is insane. And we started getting some of those paramedics who were in their prime of 20, 30 years working. And they were like, this isn't for me anymore, but I'm not ready to retire. I'm not ready to give it up. And so we started bringing them in. And I think another piece of it too, just kind of flipping the script a little bit, Sarah, is the educational piece. With us being affiliated with Augusta University, which is an undergraduate campus, we have the Medical College of Georgia, which is the 8th largest medical school in the country. We also have a College of Nursing, Zeno College, allied health programs. We started also exploring, how do we begin teaching in the curriculum earlier on to actually embed telemedicine as part of their practice, right? it's inpatient, it's outpatient. Well, now it's virtual care, right? You have three services of care delivery, and that's really what we have been working on. We've embedded within the first 3 weeks of a medical student, they are actually doing telemedicine practices now. They have patients they're actually working with and seeing, and we're starting to do the same within our College of Nursing, teaching them how to use remote monitoring tools, right? How do you understand to analyze this data and use it in a different way? So while we also have been focusing on retention and recruitment in our actual operations, we're looking at it too to say, how do I better prepare people to be comfortable to go into it? So what we have found is telemedicine is not something you can just step into and just do, right? You've got to learn how to practice and to use the digital tools. And that's really what we focused on here in our model is how do we empower our staff so they feel comfortable enough to stay in this, and then also work with them to meet that work-life balance as well.
Yeah, and I think we'd all agree that that virtual care, one, is a specialty, and that if leveraged in that way can be an efficient way to do so. I think we all agree that virtual care could be a retention strategy. So taking burned out staff and getting them in a space where they can have some of that reprieve. We're getting a lot of questions as we're getting into this topic of, okay, how do you train staff within the virtual care? What is the right, a physician, an MPPA, a nurse? How do you train somebody into virtual care? And then the other question that's been going along with that is virtual care a place for new practicing staff members? Kind of wanted to loft that question in your way. And Karam and Dom, feel free to chime in on that.
I was going to say, Lauren sort of highlighted on it. As a matter of fact, Lauren, I was taking some notes as far as how do we really now connect the schools. So we also have a School of Medicine, School of Nursing. So how do we really connect those? So I thought there was some really good insights that Lauren was sharing. So personally, it's a note that I took down that I need to connect with Lauren offline to, like, how do we really build those relationships so those students and medical students and fellows that are there, how do we really integrate them? So I think that's a learning for me as well. So I'll toss it over to Dom and Lauren, see if they want to add anything.
Dom, you want to add anything about how you train in your nurses or your care team members in general that are dedicated to virtual care?
Yeah, a couple of thoughts. One, we haven't solved all the challenges in this space. I think we're all learning how do you do a great onboarding kind of training plan, embed someone into your organization's culture, values, and that sort of thing, and do that fully remote. That's a hurdle that is beyond the healthcare industry as well. That being said, we're trying to accept that challenge, right? And so our team is doing a lot of remote training of one another. We've done our best to really simplify the onboarding into this space. So we're recruiting in staff with experience and exposure within the healthcare industry already. And so these staff today are not brand new to the nursing practice. I'll speak to that one in particular. And so many of these staff are already familiar with those foundational components of what does it look like to be a nurse and to care for patients, to communicate with other members of the care team. And so when we bring them into the virtual care space and practice, we're working quickly to bring them up to speed on how do you use the tools and the technology to your advantage? What are the workflows to be most successful and most scalable with some of those solutions? And so that's allowed us to really quickly bring members of the team on board. And then we just have a strong resource base available because our team's caring for a variety of different patient types across the nation. And so when interacting with these patients, they might not have all of the expertise readily available in their knowledge bank. And so we have, SharePoint type resources that our team members can tap into just in time to familiarize themselves with those different workflows of who's, the provider that I'm going to tap into for XYZ patient type, or what was the communication pathway based on some of the urgency around this clinical data that I was going to pursue. And so that's ways that we've had success in bringing a more expeditious approach to onboarding. gosh, we're also just encouraging our staff when they jump into the space and the practice, ask a lot of questions. Like, we want to help you be successful. And so our team has this internal communication channel amongst themselves where they're able to tap into one another throughout the day and say, hey, you know what, Sarah, I'm interacting with this patient. I've not done this one in a long time. How would you navigate this situation? And today, some of that's challenging within our brick and mortar environment. When you walk out of your room and you're like, I don't see another nurse here. Within the virtual care space, we have quick access into one another. And that's allowed us to be able to rapidly bring members of the team on board to help support and care for our patients in this way.
So let's shift a minute to success. So we being successful. So the reason why we're all here is to talk about length of stay is high, getting patients out is, hard, and patients are sitting in the hospital that could be home. How do you measure the success of a program that is meant to take patients out of the hospital? One, what does that look like? How do you go back to your CFO or others and say, well, we should spend a whole lot of money on in-home services and all this stuff to get these patients out? What does that metrics of success look like, and how you kind of explain it?
I'll go ahead and start, since I think ours is one where that is really how we've been able to continue growing, is some of the success. The first really was for us the readmission rates, right? We had on average, before we started our traditional transitional care program at the end of 19, before COVID started, was readmission rates were close to 17-18%. And so that's obviously penalties every year for the institution, not to mention the impact it had on our value-based programs. And so what we started focusing on, and I was tasked with, was putting together traditional transitional care. And we were able to lower it some, right? But then COVID hit, and that just all kind of went away. And then in February 21, when we launched this program, that was one of our main goals, was reduce readmissions. And we were able, just in the short time, a little over a year, reduce their overall health system readmission rate from that 17% down to 12%, which was fantastic. So right there, I showed this is a level of success that we're actually we're seeing real time. The other piece of it was reduction of length of stay. And where we first started noticing the impact this truly was having was in our COVID-19 patients. So we had retrospectively looked at a group of patients in a cohort, 100 patients that were enrolled in our program, and then 100 patients that were not enrolled in our program. And what was the cost difference, right? Direct cost, as well as reduced length of stay. And on average, we were reducing the direct cost of patients enrolled in our program by $11,000 per encounter, which is phenomenal. And so right then my CFO was like, okay, what you need? You need, 5 paramedics, 10 paramedics, right? And so we started building the program, and we go back and we review, not just the length of stay, which are on average, we reduce around 1.56 days, which equates to around $4,300 in savings of direct cost savings, right? I'm not talking about margins from a reimbursement, direct cost of the institution. And then we also too started noticing is that we did a great job for 7-10 days on readmissions, but those patients were still coming back on 14 day 21, right? And that's where we started creating the evolution of the model to say, I got to monitor these patients for at least 30 to 45 days. Just a simple telephone call isn't doing it anymore. And we plateaued at our readmission rate of around 12%. So that's really where we're focusing now, is starting to see how we continue to drive down readmissions. And then of course, the length of stay. And then the next biggest piece for us is we continue to add on in-home care services, from rehab to IV administration, is starting to look at how do we reduce the ER diversion hours, right? How do we start cutting that piece of it down, so that we can potentially screen these patients out of the hospital appropriately and go into an in-home care model that would allow us to improve our margins and cost around uncompensated care, and then as well as ER holds. So those are our 3 kind of metrics for success we're looking at right now.
Yeah, I'll second that. And I think in our case, we work really closely with our finance team to really be able to hone in on what is the day rate, right? If we were to be able to save 1 day, what does it equate to? And I think that really helped us quantify it and be able to showcase that, when we're sending patients home safely, we are saving around like $6,000-7,000 a day, right? So that's that you can start seeing a performance that you can put together to be able to say, okay, we can actually safely send these patients home while we're creating more capacity and shortening the length of stay of these patients. And just as I mentioned earlier, we use the same data to be able to then publish it in JAMA, right? So I think that's kind of where you can actually say that this did work. There is evidence behind it to be able to do that. And going back to the education piece, one of the things that we really enjoyed was our partnership with our partners, because they really helped us create that education curriculum, right? Because this was a net new service we're adding, right? So when you're adding virtual care, there's different flavors of virtual care you're adding. There's telemedicine, there's remote patient monitoring, mobile urgent care, and you name it. And so depending on in this case, we were doing remote patient monitoring on a post-acute basis. So really, how do we really create that curriculum? How do we really create that? So I think having the right partner at the table to help you develop that really solidify, give confidence to our nurses. And they actually took charge, and our entire discharge lounge nursing staff actually created a booklet off of that. So I think just want to leave the folks with that. Having the right partner at the table really helps drive the volume and also build that momentum around your product.
Dominic, do you want to add anything about measuring success?
Super important. I think before we measure success, we have to understand the problem that we're trying to solve for. It's one of my favorite and least favorite things to see. It's my favorite when we get it right. It's my least favorite when we come into something and we're like, wait a second, we started down a path. We didn't first understand the problem, but we've got this cool solution, right? And so we're chasing this kind of shiny object. And so that's something that we've just grown and learned over time. We've done that wrong sometimes. We haven't well understood the problem first before going and thinking about what's the right and appropriate solution to deploy. And Kerm and Lauren have also outlined this too. We have to understand the problem first and deploy the appropriate needs based on that patient and that patient population. And so I think that that's important for sure to call out. The other piece that we pay a lot of attention to, and Lauren, I took note of this as you mentioned it, is counterbalances. And so when we shorten length of stay for a patient, we have to also think about what is the downstream impact of that, because we might just create a lot of extra access to the healthcare environment when, gosh, Lauren spent less time in the hospital and she accessed the ED a number of times because of it, right? As an example. And so as we trim down on those length of stay metrics, we also have to look at that ED readmission rate, other sorts of things like that to assure that we aren't impacting the quality of the dismissal or transition process for those patients.
Oh, that's a fantastic point. Yes. Anybody can dismiss a patient early, right? You could say, oh, great, 2 days, you're good to go. But are we supporting them through that dismissal into their transition of home to ensure success and have some wraparound monitoring at the end of that? I do want to ask, because this is coming up in the chat as well, and Kerm and I have had conversations about this, is there's so much out there. You could have 40 different devices that can do all these different metrics and biometric, things, and you can do the video things, you can do all this stuff. What's the approach, Karam? What I'm setting you up for, but do you just go out and start buying like hundreds of devices and doing that, or what's kind of the approach at UCI in terms of trying to get everything in one and make it easier for your teams?
Wow, you're putting me on the spot. What problem are we solving, right? And I think going back to what Dom said, I think that's kind of where we go back to. What is the business problem? Are we understanding the problem and then finding the right solution? There are a lot of shiny objects out there. It's like, how do we really bring it back? And you cannot have point solutions. If you're there, there's a lot of RPM companies, there's a lot of monitoring companies, there's a device every day that we get pinged about. But how does it then integrate back, right? There's this technical debt that we have to worry about. How do we then create it within our ecosystem that it is not hampering our ability to then move forward? So those are certain things that I think about when I'm looking at companies or thinking about the overall ecosystem around just care at home, or not, or in general. What are some of the vendors or partners that we want to bring to the table? And also at the same time, how does it play well with our partners that are already at the table that we are working with, we're not trying to cannibalize that either, right? So creating that synergy between them, I think there's so much opportunity that we already have at the table because of the partnerships that we have. Just going back to the wraparound services, when you send patient home, there's monitoring you can do, there's care in the home that we can deploy on a post-acute basis, there's transitional medicine, there's early discharge or timely discharge. So there's all these programs that we are thinking about just with our current partners. And then how do these new entrants in the market evidence, we want to look at the evidence that they have been able to prove quality and outcomes to be able, and then we can probably let them in the door. It's kind of like dating and then marriage. Once we're in a marriage, it's really hard to divorce and expensive. So I think we want to really be very cognizant about the partners that we're bringing to the table and how do we really work together to really push the needle for our patients, our clinicians, our administrators, because at the end of the day, the burden lies with us.
Yeah, and do you have a platform that can facilitate kind of multiple different use cases as well too? And how do those ecosystems play with each other? Um, there's a question in the chat that I think is good, that we could end on. How do we kind of reduce that digital footprint? So again, going back to the many different devices, and as we talk about getting patients out of the hospital earlier, we also have to grapple with, do they need continuous monitoring? Do they need, you can go down a whole other rabbit hole on continuous, and what that looks like, but how do we simplify, or how are you simplifying your digital footprint for your care teams that have to interact with all of the devices to provide care? Do you have any strategies for people?
I'll start and then jump in and see, just so this is our perspective is, I'm not hiring a nurse to be a IT troubleshooter, right? Well, that's not what, Dom, you talked about that earlier, but unfortunately that's what they become, right? And so for us, when we started this journey, we were really just like I said earlier, fingers in the hole, trying to stop the water coming out of the dam. But as we got comfortable, we recognized, okay, what do we really need, right? Well, what's the problem we're solving for? And looking at the vendors, the one piece that I really wanted in a vendor for me to help reduce the amount of devices and the plugins and the add-ons and everything else in between was a vendor who understood our vision. And I think that's important, is you can get overwhelmed with all the amount of devices and using them, or figuring out how to use them or not to use them. But I think for us, what we really focused on is finding a vendor who really and truly understood our vision and had a seamless platform. And that was important, is one platform that really allowed us all of the access to the peripherals we might need. Now, there may be some one-offs, as an example, EKGs, right? We get a single lead EKG from Continuous, but I need a 12 lead. So finding a device like that, those are going to be your one-offs. And I think too, it's part of your strategy. What are you going to deliver in the home? You need to start asking yourself that. What are your capabilities going to be? And which ones are you not going to provide in the home when you're doing more timely discharge and, or chronic disease management? When you get into the acute care space, that's a little different. You've got to have those devices in order to meet the needs for meeting the requirements. But when you're in this, I think ask yourself, and that was for us, is we weren't able to solve every problem at one time. And so we started identifying from the cohort of the patients we're servicing what truly the devices we need. And then when it started getting to where, okay, I'm starting to see A, B, and C, then we go back to your vendor. If your vendor can't help, well, what vendors have you worked with? How do you have that? And to have those open conversations, I think that's important as you are trying to enhance your program. Don't overwhelm your nurses staff. You reduce it by being simplistic. Overkill, shiny, bright, and shiny doesn't always mean it's the best, right? Simplicity, and for your patient's sake as well too, because some of these patients are not tech savvy enough to deal with the complicated components of having to deal with these devices. Make it simple for them too, because at the end of the day, they should be in the center of our decisions and the reason why we're making the decisions and what we're making them for.
Yeah, no, that I think that is a fantastic end note to this webinar. I can't thank Kurum and Lauren and Dominic enough for sharing your expertise. We did not even come close to getting all the questions, and happy to have people reach out if they wanted to have more conversation. But on behalf of Bioformis and American Telemedicine Association, just want to say thanks all for joining and for listening on this important topic.
Thank you.